Perfect. So now we are ready, and we have the last presentation of the morning session by Dr. Carola Caucig from MedAustron on Ewing and Rhabdomyosarcoma. I can hardly say the words. So please go ahead. The floor is yours.
Oh, thanks a lot. Thanks a lot for the invitation. And also thanks a lot for giving me the opportunity to talk about Ewing and Rhabdomyosarcoma patients. I'm a radiation oncologist working at MedAustron. I'm leading the pediatric and CNS program, and I'm the clinical director since 1 year now. Talking about Ewings and Rhabdos in this very illuminated session is also an experience for me because, to be honest, Ewings and Rhabdos are pediatric cancers that show good response to conventional therapy concepts, which normally consists of chemotherapy and radiation. They're not really the indication for heavy ions, for carbon ions. But nevertheless, I will talk about the disease and try to give you an overview. Wait, I try to. Oh yeah, now this works. Do you see the second slide now?
Yes, very well.
Sarcoma? Okay,
yes,
wonderful.
Well.
So, pediatric cancers are rare tumors. It's a very heterogeneous group, as you can see here on the right side. Kids can be affected by a lot of different tumors, like the majority actually are leukemias and CNS tumors, but there are also other tumor entities like bone tumors and soft tissue sarcomas, but they only account for 7 or 4% of all pediatric cancers. The overall incidence is low, but it is increasing since the 1970s. That does not mean that we have more sick kids. It's just that the diagnosis is now made more often. And but there's also an increase in survival that we can see since that time, because therapy concepts changed a lot for peds. This increase, on the other hand, also had a price, because what we see now is an increase in childhood cancer survivors, but they are also suffering from therapy-associated toxicity or health conditions, which then are leading to psychosocial burden for survivors, but also for their families and caregivers, and also for financial burden for the whole healthcare system. This was one of the articles that was really striking when it came out. Published the results of patients that survived childhood cancer, and then in the end, 30 years later, they were still alive, but unfortunately they had severe disabling, life-threatening conditions, or died due to chronic conditions of their cancer treatment. So what can we do, or what is radiotherapy? Because radiotherapy, of course, also plays a role in role for this. What can we do is that we try to use the indication, we try to reduce the indication, we try to reduce the dose, we try to reduce, of course, the target volume, but also if we still need to irradiate, we should, whenever feasible, try to use particles, protons. Because these kids, they survive now, their tumor, they will survive for decades, and they really are at risk of having this long-term toxicity. So all these modern therapy concepts in pediatric cancers are now multimodal or interdisciplinary. They are based on interdisciplinary treatment strategies. You have different therapies, therapy approaches. Normally it consists of surgery, radiotherapy, chemotherapy, but also more and more targeted therapy and immunotherapy, also in peds. Most of the kids are treated within protocols or according to protocols or international studies, because it's, in the end, the incidence is low, it's a rare cancer, it's very heterogeneous. So to get more information and to really create evidence, we need to treat them. We need to pull the data. This is why they all should be treated within the protocols. Most of these therapy concepts are now risk-adapted therapy strategies, meaning like what we also do now in adults, that in Hodgkin lymphomas, for instance, that you start with chemotherapy, that after 2 cycles you do restaging and you reassess the tumor stage. And then if based on the response, you decide to intensify the treatment or to decrease the intensification of the chemotherapy, for instance, but also to set the indication for radiotherapy. This is then also these so-called response-guided therapy strategies. And in peds, of course, if possible, use protons because of the physical advantages over photons. So rhabdomyosarcomas. Rhabdomyosarcoma is a soft tissue malignant tumor, childhood mainly in children, and it originates from the mesenchymal cells. The incidence overall is low. It's 2.7% of all cancers among the young children, younger than 14, and 1.4% of cancer cases among adolescents. But the majority of patients diagnosed with rhabdomyosarcomas are really the young kids, so younger than 10 years. There are genetic risk factors identified, like Li-Fraumeni cancer syndrome, DICER1 syndrome, neurofibromatosis, and others. Histologically, we can distinguish between alveolar, embryonal, spindle cell, sclerocytic, and pleomorphic subtypes. The majority in the young kids are embryonal histological characterization, and when it comes to adults, the majority are alveolar. There is now more and more also the molecular approach, especially the new treatment protocols. This is also taking into consideration the FOXO1 gene fusion. FOXO1 gene fusion positive patients have better prognosis. Most of them are embryonal histology. When it comes to the localization of the tumors, the majority are located within the gastrointestinal area. A quarter is head and neck, and including also parameningeal involvement of parameningeal areas, and up to 13% are located in the extremities. Prognostic factors is young age, so younger children normally have better prognosis. Also, younger children also tend to have more FOXO gene, so they have better prognosis. They're embryonal. Normally, embryonal subtypes have less nodal spread. Then also the tumor size at diagnosis, so smaller than 5 centimeters, is associated with better prognosis. Of course, if you can resect the tumor, it's also associated with better prognosis. And as in all tumors, as expected, distant metastases have worse outcome. And what is also very much important is the response to therapy, to induction chemotherapy. Patients that show good response to chemotherapy tend to have better overall survival. So this is also here what you see regarding to the tumor site, that this is really associated with better overall survival. For instance, orbital rhabdomyosarcomas have a 5-year overall survival of 97%. And this also then reflects why these tumors, for instance, can be treated with even less dose compared to others. Rhabdomyosarcoma are the prognostic factors. So at what stage normally we see the patients for the first time? So only 15% present with localized disease, which can be completely resected at diagnosis with no lymph node spread. About 16% have localized disease, which can be resected with macroscopic residual or regional disease. But the majority have localized or regional disease, which can only be diagnosed with by a biopsy. That are not resected, so they have this complete treatment approach, chemotherapy. Then after, normally in week 13, they have a reassessment and local therapy, which normally is surgery and radiation, or if surgery is not possible, then radiation alone, followed by another 6 cycles of chemotherapy. About 20% already present at diagnosed with distant metastases, which are mainly treated with high-dose chemotherapy, and also now more and more with radiation, because radiation is for local treatment is very essential and effective in rhabdomyosarcomas, even in metastatic tumors. And I will show you in the end also the new European protocol, where all initially metastatic sites are also irradiated now. So according also to the spread and the histology, rhabdomyosarcomas are then allocated into different risk groups: low, standard, high, and very high risk group. And according to this risk group, then the therapy approach is set. The treatment options is all children require multimodal therapy with systemic therapy in conjunction with either surgery and radiotherapy, or both, to maximize local tumor control. Resection upfront is only performed if it is not leading to any organ dysfunction in the kids, because normally we expect the tumor to respond very good to chemotherapy, to downsize, and then to reevaluate if resection is possible, or otherwise perform local radiation. So the group 1 children, normally after complete resection, only adjuvant chemotherapy is given. The group 2 kids, which are about 20%, they receive chemotherapy and a local tumor bed irradiation. So these were the children that also had resection. But the majority of kids, they have initial chemotherapy, then they have definitive radiation or subtotal resection plus radiation. And this 15% of high risk, already metastatic diagnosed kids receive chemo and adjuvant radiation. So what about the data if these children are treated with conventional treatment approach? So chemoradiation, this parameningeal alveolar, this is a very high risk group. So parameningeal, as I told you, is already from the location a better prognostic factor. Alveolar is also worse prognostic compared to embryonal. But even in these really high risk patients, and in these cohorts, also 1/3 had null spread at diagnosis, you overall see a 3-year local control rate of 66% and the overall survival of 60%. The main failures were local or leptomeningeal, because this is always an area where you tend to underdose, or and also an area which normally does not respond to chemotherapy very well. So in these patients, one might think of maybe a dose escalation, but this has to be clarified in further studies. Nevertheless, this confirms alveolar histology as higher risk of nodal involvement. Intracranial extension has poor prognostic factors, but it does not translate in overall survival. So this is a patient now which was treated at our center with a parameningeal rhabdomyosarcoma. The child was treated according to the old EPSSG RMS protocol with chemotherapy. After 9 weeks of chemo, he only showed minor response. No surgery was possible, and he was prepared to proton therapy. We were treating with a simultaneous integrated boost with PTV1 to 50 and PTV2 to 55.4 gray. This is at that time we also had to make a comparison with photons, because when we started a lot of patients, we had comparison plans to evaluate really the benefit of protons. And what you very nicely can see is in the dose differential, the sparing of the oral mucosa, and also of the dose to the, does the video does not, oh yeah, now it runs, yeah, sorry. And also the dose to the CNS, which is very important if for the little kids. What also is important, especially if you give chemoradiation, is to spare as much as possible the mucosa, because the children normally suffer from mucositis due to chemotherapy anyway. So we don't want to give them another, or we don't want to increase the mucositis with radiation, or keep it as low as possible at least. So this is another case of a 10-year-old child, also diagnosed with a parameningral rhabdomyosarcoma, and in this child was also treated with chemotherapy, but according to the FAR-RMS protocol, which is now the protocol also initiated in Austria, and but I think it's used in a lot of other European countries. In Great Britain use it, and the colleagues in Israel also use already the FAR-RMS protocol. What you very nicely see here is this normally typical response to chemotherapy. You have in the upper part, the upper two images show the tumor at diagnose, and the lower two images show the coronal and axial view of the tumor at time of radiotherapy. So you see a very good response, and this also explains why we don't see any need for carbodynes, of course, in these patients, because in the end, the radiation is just consolidating within the area of the primary tumor extension plus a margin. And also in these locations, the goal is we cannot spare everything, but at least to spare the eyes and the brainstem, and also mucosa as much as possible. Orbital rhabdomyosarcomas are by definition tumors with low risk. So this is why for orbital site, the goal is maintaining the good local control rate, but reducing the long-term toxicity. These tumors are treated only with maximum of 45 gray, with in the 36 to the primary tumor extension, and then only 9 gray boost to a residual tumor. The 5-year overall survival rate in this cohort from Jacksonville was 97%, and the overall survival was 100%. So this confirms a very good prognosis of these tumors. They respond good to chemotherapy, and with the consolidation of this 45 gray of radiation, you have an excellent overall survival with only serious late toxicity in only a very small cohort of patients. Pelvic rhabdomyosarcomas are also per definition normally associated with good overall survival and local control rate. This is also published by the group of Danny Indelicato from Jacksonville, showing or confirming what is known from the literature. So I just want to show you that strategy that we at the moment follow in Austria, because the kids in Austria are treated now within this FAR-RMS protocol, which has a lot of questions, or wants to question a lot of answers, and also has a radiotherapy question. So radiotherapy is given to the majority of patients also within this protocol, but there is a standard dose and a dose escalation arm. And also another radiotherapy question is radiation to all metastatic sites versus only primary tumor. So this will be very much interesting when we will see the results in a couple of years from now. Regarding the dose within the protocol for, so in patients with resectable disease, postoperative radiotherapy is always given. There's only a few exceptions. Postoperative is 41.4 gray, and for patients with high local failure risk, the standard dose will be still 41 gray, but there is the possibility of a dose escalation. You can randomize into a dose escalation with 50.4 gray. In patients with unresectable disease, the dose can be even escalated in high local failure risk patients to 59.4 gray, which actually is the dose which was also given in the COG protocols. Nodal disease is also all initially initially involved nodes are irradiated with 51 gray, and there is also a escalation to 50.4 gray for those for nodes which are still enlarged at time of radiotherapy planning. The same for metastatic sites. All metastatic sites, initial metastatic sites will be treated with 51.4 gray. And if in case of bulky macroscopic residual metastatic disease after induction chemotherapy, it can be even escalated to 50 gray. So these were the rhabdomyosarcomas. Now we'll talk about the Ewing sarcomas and also the undifferentiated small round cell sarcomas of bone and soft tissue in pediatric patients. So Ewing sarcomas originate from the primordial bone marrow driven mesenchymal stem cells. The older terms used were primitive peripheral primitive neuroectomal tumor or Askin tumor, the Ewing sarcomas in the chest wall. Or extra-osseous Ewing sarcomas, often combined in the term Ewing sarcoma family of tumors. Before the widespread availability of genomic testing, Ewing sarcomas was only identified by the appearance of these small round blue cells on light microscopic examinations, along with positive staining for CD99 by immunohistochemistry. Now there is also it is only in addition we have the genetic or molecular testing and the translocation and involvement of the Ewing sarcoma breakpoint region 1 gene on chromosome 22 band Q12 and a number of pattern chromosomes is the key feature of the diagnosis of Ewing sarcoma. In the WHO classification of 2020, they introduced a new chapter on undifferentiated small round cell tumor, small round cell sarcomas of bone and soft tissue, and these also included undifferentiated small round cell sarcomas with BCOR genetic alteration, with SIK genetic alteration, and with this Ewing sarcoma breakpoint region 1 non-ETS fusion. There is an agreement that these tumors, because before the classification, they were all treated within the Ewing sarcoma protocols. But it seems that they are a completely different entity, but they are very rare, and we really have to get more knowledge about them. But nevertheless, their therapy is similar, so they will not require some new studies. So what is the Ewing sarcomas? The incidence is normally in the not so young children. The majority of children are older than 15-year-olds. So compared to the rhabdomyosarcomas, where only where the majority are the really little kids, now we talk about the teenagers. The median age of patients with Ewing sarcoma is 15 years, and from the location, we can distinguish between osseous and extra-osseous tumors. And the osseous tumors, the majorities are located in the lower extremities, followed by pelvis. And extra-osseous are mainly located in the trunk, but also extremities, head and neck, and retroperitoneum. Risk or prognostic factors for Ewing sarcomas, there are pretreatment factors and response to initial therapy factors. The pretreatment factors is also tumor site, very similar also to the rhabdomyosarcoma. So patients with Ewing sarcomas in distal extremities have better prognosis, maybe also because it's detected earlier, because a tumor in the lower extremities, of course, you can touch, you can see, maybe the kids, they have pain when they do sports, when they play football. So patients with Ewing sarcoma in the proximal extremities have an intermediate prognosis, and patients with the central or pelvic sites have the worst prognosis. These are normally also tumors that are identified at a later stage, they're normally bigger, and because the pain from the pelvis comes later. Extraskeletal versus skeletal primary site. It seems that extraskeletal primary site is statistically significant better prognosis than patients with skeletal primary tumors. Then, of course, the tumor volume, whereas in Rhabdos it was 5 centimeter was the cutoff. In Ewing sarcomas, it's 8 centimeters. So larger than 8 centimeters associated with the worse outcome. The age, in Rhabdos, it was the younger age, had a better prognosis. In Ewing sarcomas, infants and younger patients also have a better prognosis than the older ones. I don't know. I mean, there's a lot of other they're called risk factors. I don't know if this is. I mean, this is maybe some statistics somebody did. So girls have better prognosis. I don't know if this is true, but at least somebody did the statistics for it. And an increased LDH and at diagnose, and also the presence of metastases are associated with adverse prognostic or adverse outcome. This is also, I think, totally clear, and it's the same for a lot of other diseases. So, response to initial therapy. So patients that do not respond to initial chemotherapy or have a lot of viable tumor cells in the specimen associated with worse outcome compared to the ones that had only minimal residual disease or minimal viable tumor cells. And in this entity, the decrease of PET uptake after chemotherapy is also correlated with the good histological response and better outcome. For rhabdomyosarcomas, this is not clear, the PET decrease, and this is also a question which is addressed by the ongoing FIRE-MS protocol. So the treatment strategies for Ewing sarcomas is the same with rhabdomyosarcomas, and with majority of kids that the patients require systemic therapy in conjunction with local treatment, which is surgery plus radiation for the local tumor control. The chemotherapy normally consists of multi-drug chemotherapy, which always includes vincristine, doxorubicin, ifosfamide, and etoposide. The local therapy, surgery plus radiation, is a locally aggressive therapeutic approach, and must be justified to maximize local control while minimizing morbidity. But this is in the adults very similar, but in peds this is even more important. And surgery is the most commonly used form of local control, and radiation is an effective alternative modality. And in cases where the function or cosmetic morbidity of surgery is deemed too high so then the radiation is performed instead of surgery. Radiotherapy is usually employed in following cases: so patients who do not have a surgical option that preserves function and cosmesis, and in patients whose tumors have been excised but with inadequate margins, and preoperative radiation if gross total resection is possible but without inadequate margins. Then preoperative radiation with 54 gray is also recommended. The standard dose varies between 45 to 55.4 gray in Ewing sarcomas, where the 45 normally is after gross total resection, right resection, and good response to chemotherapy. The 55.8 is at the moment the standard dose is in the European protocols for postoperative radiation with inadequate response to chemotherapy and subtotal resection or definitive radiation. In case of lung metastasis, a whole lung radiation is also recommended even after complete response to chemotherapy, whole lung radiation with 12 to 15 gray. So treatment outcome of Ewing sarcomas, there seems to be a dose effect relation. So there is data on dose escalation trials that even show a better local control rate. So there is, I think, definitely room for dose escalation. I don't think that there is room for carbon ions, but I think that overall dose, which is normally given in Ewing sarcomas, is not very high with this 50 between 45 between and 55.8 gray. But this comes from times where children were not treated with high dose because we were afraid of toxicity. But in times of protons, it's possible to increase the dose with the goal to also increase the local control and overall survival rate. So I think for a selected group of Ewing sarcomas, like large tumors, pelvic tumors, dose escalation really could bring a new benefit for the patient, even increase the already good results of therapies for Ewing sarcomas. So prognostic factors, yeah, I think we already mentioned, and these should be also then the indications for dose escalation trials. So this is one patient that was also treated at our center with a large pelvic Ewing sarcoma, and patient was initially had a biopsy, then was treated according your Ewing protocol. After 6 cycles of chemotherapy, he showed response to chemotherapy. So in June 2019, the tumor was resected in terms of a hemipelvectomy, and he had an extraosseous radiation of the bone, which was at that time a therapy approach which was performed at the Medical University of Vienna. So the surgeon resected the tumor, he took the bone out, bone was irradiated with 1 × 100 gray to sterilize it, and then the bone was put back that the child can still uses his hip, but of course it was known that after after some years he would require a hip replacement. But for that time it was that strategy was to keep, at least for the first years, the hip joint. But as you see, the tumor was resected, and if you just irradiate the bone, there's still the margins that are of course positive. So this child still needed to have some postoperative radiation. So he was treated with the protons due to tumor extension. And the Planck comparison between photons and protons could very nicely show that its organ at risk is not only bowel, but it's in a young boy, of course, also the penis. We could reduce the dose to the genitals, the dose to the acetabulum, where, the anus, and yeah, here we go. Here we have the video where you can really nicely see also that the goal was, beside the bowel sparing, also the sparing of the hip and of the femoral head, because if the surgeon tries to spare it, and here you see it, tries to still put the bone inside, that the child has still the function of the leg, then you should also spare the femoral head. So this is an example of Ewing sarcoma of the scapula. This was also a child which was treated at our center, a 14-year-old girl. She was referred from another center in another country. That was the child was treated according to the COG protocol, so the American protocol, and showed good response to chemotherapy, and had unfortunately only minimal bone margins, so adjuvant radiation was indicated. With this center, we also had to make a plain comparison, and the goal was, in this situation, to spare the lung. And protons, and also the breast tissue, because she was a 14-year-old girl. Of course, there is not a lot of breast tissue, but each dose to the breast, as we know, should be avoided due to secondary malignancies. So in summary, rhabdomyosarcomas and Ewing sarcomas are pediatric bone and soft tissue sarcomas, which have overall a very good prognosis, show a very good response to standard chemoradiotherapy. And for the moment, there is no evidence that carbon ions could be an option in the standard indication for these malignancies. There might be in future a therapeutic window for carbon ions, especially I think in these high-risk patients with different genetic alterations, but this is something that has to be proven in future. And there might be also, or there is, or we have treated 2 or 3 kids with carbon ions with Ewing and rhabdomyosarcoma with early infield recurrence. So there we guess that patients had a different histological subtype. So, and here this is also the end, and I thank you for your attention, and I'm open for questions.
Thank you very much for all these details, and yeah, I mean, this is a challenging job you have with pediatrics. So there are no questions in the shared document. There is one here from our colleague from QST, Dr. Reiko. Please go ahead and unmute yourself and ask the question.
Thank you very much for the great lecture. Thank you very much. May I ask one question regarding Ewing-like sarcoma, like a B-core CC, NB3, and CIC rearrangement sarcoma? I think those tumors are a bit worse radiation reaction compared to Ewing sarcoma. So do you modulate the total dose for such a tumors, like dose escalation or something?
Yeah, we do so. I mean, it depends very much if it's a resected tumor or not. And also if it is a child that is treated within a protocol or not, because if it's within a protocol, it's very difficult because if it is not within a protocol, we had one child with a sick mutation, and we escalated the dose. We were treating like a high-grade sarcoma. We was but we stayed with protons because it was marginally resected, but we boosted the resection cavity up to 66 gray.
66 gray. Thank you very much.
But
thank you.
But he failed outside.
No,
he failed. So it was locally controlled, but he failed outside. And I think only a couple of months later, he was.
And in such a case, did you try to re-irradiation for such a case?
No, he had distant metastasis, so he failed outside no.
Okay. Thank you very much. Thank you.
So please raise your hands if there are more questions. I do not see in the chat. I don't see raised hands, and we don't have in the shared document. Okay. Then maybe I can ask a naive question. Somehow we hear more and more about personalized therapies. And here you talk a lot about protocols. And then my naive question, is it something that is related to insurances, or it is the doctors that they follow certain prescription, and how much freedom a doctor has to do something different than the protocol? For example, you mentioned some cases where you used actually carbon ions.
This was off protocol. So normally, if these kids
Yeah.
are really treated in a protocol, you have to discuss it with the study center, and it makes it sometimes really difficult because sometimes not everybody fits into the protocol. But as these are, I mean, the incidence is overall very low. And for instance, I mean, we treat the majority of or the incidence in Austria is 200 pediatric cancer cases per year. And if you have 4% Ewing sarcomas, you can imagine how many kids you normally see per year. And to really get the expertise and also to get the data on the pediatric cancers, they're actually completely different to the adult cancers. It is important to treat them within the protocol, to try to stay within the protocol. In case of recurrence, then we go totally into the personalized medicine. Then there is a lot of things open. The carbon ions were re-irradiation, in-field re-irradiation, and in an early recurrence. So of course, there's something if the child then is not in a protocol that would not allow to do it. We really try to go then for the more aggressive ways. But for the standard approaches, we have very good results. I mean, you saw these big tumors, and you still can achieve with this standard approach with low long-term toxicity up to 80-90% overall survival. So I think for the majority of kids, these treatment approaches are fine. We should try to stick to the protocols also to get more information. Also about dose escalation, for instance, or the value of PET in rhabdomyosarcomas, which also I think would be very much interesting, because in the end the goal is we want the kids to survive, but we want to reduce the overall long-term toxicity and morbidity.
Okay, and one more question, if you have the time. You mentioned that you irradiate also metastasis. Yes, in some other cases, we hear that once there is metastasis, there is no indication for carbon ions, for example. Somehow naively, I would think, since we heard all these presentations in the beginning of the sessions on Monday, that there is a relation between irradiating with carbon ions and waking up the immune system, that this would make sense, no? And irrespectively if it is in the protocol, one would try to go like this. What is your opinion on that?
I mean, for the pediatric patients, as I told you, we try. We don't use the carbon ions. We only use the protons.
Yes.
And if you treat kids, you really try to do everything to make them survive. And it seems also that especially in the Ewing sarcomas, you really should give also treatment to metastatic sites. But the value proven within a big study has not been shown yet. So this is for the Rhabdos now the first study that randomizes in metastatic patients between consolidation of all primary involved metastatic sites via radiation versus patients only treated with chemotherapy alone. So this is a question that will be answered in, I guess, 5 to 10 years from now. But we expect, so from case series, we expect that they really benefit from also treating the metastatic sites.
Okay, thank you very much. Still, I do not see any other questions, raised hands. So then I think here we'll thank you and all the speakers of the morning session for those very interesting presentations, sharing experiences. And I hope among you, the doctors, sharing this experience, you will advance for better therapies in the future. Thank you very much, everybody. And then we break for lunch and we reconvene at 14:15.
Thank you.
Thank
Bye-bye.
you very much.